We're in business.
Excellent. Okay, so we're going to discuss the update for acute flaccid myelitis today. We're going to start with a clinical presentation. We have a 6-year-old male with a history of persistent asthma who comes in with a history of 4 to 5 days of neck stiffness, followed by cough and right arm weakness for 2 days. Upon taking the history from the family, the progression of symptoms appeared to go from neck pain to headache and fatigue, followed by trouble keeping his neck upright, associated with right forearm pain, and then finally right arm weakness. On the day of presentation, he's noted to be febrile to 103. Moving.
I think you have to give us privileges to advance the slide, or someone will, Danita will have to do it.
You guys do have presenter rights. Dr. DiBiase does.
For some reason, it's not advancing.
Would you like to take charge of the screen and I could just tell you next slide? Would that be
Yeah, what?
a little more seamless?
Danita, why don't you push it back to me?
Okay. Okay, Dr. Weissman, share your screen.
Thank you so much.
Here we go.
Okay. Next slide.
Hang on. Coming.
There will be zero correlation. This is during my performance about incident, so she was like, you're so much right. And if you're not CHD, you're going to fall the shoe.
Yeah. Okay. Oh, go back one. If you wouldn't mind. Thank you. Okay, so he presented to an outside hospital emergency room twice. On the first visit, he had a general exam and had a CBC and CMP that were unremarkable. He was discharged to home with a diagnosis of a viral syndrome. The symptoms persisted, and he represented to the ED. And the second time, he was febrile, and there was a concern for pain with neck movement, so he received a workup for possible meningitis. A head CT showed no acute findings. A lumbar puncture revealed CSF, significant for a pleocytosis of white blood cell count of 43 with a lymphocyte predominance and an elevated protein of 57. He was started empirically on ceftriaxone and vancomycin and then transferred to Children's National and admitted to the PICU. Next slide, please. On the first night of hospitalization, he was noted to have an oxygen desaturation during sleep and was placed on an oxygen supplementation via nasal cannula. On his history, he had no exposure. His exposures were significant for no foreign travel. He lived with a dog. He had no tick exposure, and he had had multiple mosquito bites over the summer and fall. He also had 2 siblings with current upper respiratory infections. His immunizations were up to date, and on review of symptoms, he had never had an episode like this before. He had no visual symptoms, no nausea, vomiting, or diarrhea, and no bowel bladder dysfunction. Next slide. On physical exam, his vital signs were significant for a respiratory rate of 32. Vital signs were otherwise stable. On general exam, he was noted to be agitated but consolable. And his general exam was fairly unremarkable except for this question of meningismus, where he had no neck stiffness per se, but was very agitated when people tried to passively range his neck. He had a negative Brzezinski, but a positive Koenig, where folks, when the exam, they tried to move his thigh to extend his leg, he had pain in his lower back and buttocks. Of possible significance, he was noted to be tachypnic, but had no increased work or breathing per se. Next slide. On the neurologic exam, again, he was agitated, but otherwise was able to cooperate and participate in the exam. He had no specific dysarthria or aphasia, but it was noted that he had a paucity of spontaneous speech. His cranial nerve exam was normal. He had normal reflexes. His sensation exam was normal as well. And on the motor exam, he was noted to have proximal weakness of the right upper extremity. And in the exam, they documented that when they held his arm over his body, that it sort of fell flaccidly. He did, though, have preserved grip strength and finger movements. Also of note, he was unable to hold his head erect. He had no dyspmetria on exam or tremor, and he was unable to sit unassisted. Next slide, please. So he was worked up with the possibility of having acute flaccid myelitis and went on to have an MRI of the spine, but because of his inability to hold his head up and the oxygen desaturation, was intubated. And when the MRI was obtained, it was noted that he had increased T2 signal in the ventral gray matter through several segments in the cervical spine. So this is the case we're going to present. I'm now going to move over to Roberto DiBiase, who can present some information about acute flaccid myelitis. Epidemiology.
Next slide. So, this is one of about a dozen cases we've now had at Children's over the last 4 years. And like other centers, it's intermittent, and we try to keep our awareness of this ongoing throughout the period, but there are these spikes, which we're going to talk about next. So as you probably know, AFM is a polio-like syndrome, so it really looks like a child with polio back in the 50s. And it's characterized by sudden onset of flaccid weakness in one or more extremities, and is characterized by this very distinctive pattern on the MRI that Jessica just showed you, where the gray matter or the anterior horn, there are lesions in the spinal cord in that area. The clinical features is there's rapid onset of asymmetric extremity weakness, and just like this child, it's a proximal weakness predominance. There's decreased or flaccid tone, absent deep tendon reflexes. There can be bulbar symptoms, and I'll show you a photo of them in the next slide. And there may be stiff neck, headache, or pain like this child had. Mental status, sensation, bowel, and bladder are usually preserved. Next. So this is, on the next slide, an infographic that the CDC has put out really to get the public aware that these are some of the bulbar symptoms that might occur. So droopy eyelids, difficulty moving the eyes, a facial droop or weakness, difficulty with swallowing or slurred speech, and then, of course, the sudden arm or leg weakness, which once it's pretty dramatic, parents recognize that. But these are some of the other more subtle signs. Next. The case definition that the CDC formulated in 2014 has been refined over the last 4 years, and this is the current case definition. So there's, like all case definitions that are epidemiologic, there's a clinical criteria and then a lab or radiographic criteria. The clinical criteria has been expanded to include any age, and it's an illness with onset of acute flaccid limb weakness. The lab or radiographic criteria to be confirmed as a case of AFM must have the MRI lesion that we talked about, which is restricted lesion mostly in the gray matter in the central part of the cord, spanning one or more vertebral segments. And we have seen some that are more restricted over 1 to 3 segments and others where it's a large part of the cord. One thing that's been appreciated over the last 4 years is that a negative MRI in the first 72 hours after the onset of the weakness does not rule it out, and these children really do need a repeat MRI to confirm, that they don't have this confirmatory lesion. If they don't have a capability for an MRI or, it's negative, it is still supportive if you have the acute onset of the limb weakness with CSF pleocytosis. Next slide. So the epidemiology since 2014, I'll show this to you graphically, but essentially there's been a large spike every other year since 2014. So we've had these outbreaks in 2014, 16, and now 18. Every time the cases seem to be occurring mostly August through November, and mostly in young children with a mean age of 4 years of age, but up to 32 years of age. It's still extremely rare, less than 1 to 2 million children in the U.S. per year. And now that more data has accumulated for these 420 patients in the last 4 years, over 90% have had a mild respiratory illness or febrile illness before developing the onset of the flaccid myelitis. Importantly, all of the stool specimens have tested negative for polio, so we know for sure this is not a recurrence of poliovirus. But we don't have a definitive cause, and we'll give you a little more information about that in a moment. But one point I wanted to make is that the clinical entity of acute flaccid myelitis is not new. So poliovirus did it back in the 50s, and we know that West Nile virus and enterovirus can also do it. But really since 2014 is where we're seeing this more dramatic spikes and more associated with enteroviruses. Next slide. So this is just graphically and just putting it in words. So you can see in 2014 when we first appreciated this, and this was really emerged in Denver, and our colleagues there were the first to describe it. There were 120 cases that eventually involved 34 states, and then it sort of went away. There was just a few, 22 cases in 2015, but then again it came back in 2016 with 149 cases over 39 states, including D.C. 2017, again, the off year, there was only 33, and now in 2018, there have been 119 confirmed cases, and there are at least another 100 that are still undergoing the review of the surveillance to see if they meet the criteria. Next slide. So this is just graphically showing you that they are clustered in the June to November time period in each of these two-year intervals, and the peak incidence is in September, and that's true of this year as well. Next. And this is just graphically showing you that it's not restricted to a particular geographic region or state. It's really involved almost all the states at this point in one of the spike years. And this is important when we talk about etiology of, is this potentially a toxin or something? It doesn't appear to be because it's so widespread. Next. So this is a demographic summary that the CDC put out in their MMWR publication that comes out weekly. And this was a description of the first 80 confirmed cases from this year. We now know that number's up to 116, but this data is going to talk about those first 80. So the median age was 4 years, ranging from 7 months of age to 32 years of age, but the vast majority, 94%, are pediatric, less than 18 years of age. There's a slight male predominance, 59%. As I said, 80% in this first part, and now 90% with all of them had a preceding respiratory or viral illness. The median onset between that illness and the onset of the flaccid weakness is 4.5 days, but has been as long as 2 months. And the distribution is really markedly overrepresented by upper limb weakness. So 48% of these cases present with upper limb weakness only, and about 10% with lower limb weakness only, and the remainder are a combination of upper and lower. 60% are admitted to the pediatric ICUs, and like the patient we presented, they often have a CSF pleocytosis that is mild to moderate, so 50 to 100 cells, lymphocytic predominance. Next. This is a really important study that was published by the Colorado group who first appreciated this. So they took the first 12 children that were really the reason that we're all aware of this now from 2014 and put together a multidisciplinary clinic where they actually evaluated these children every 3 months for a year period to determine the outcome. Because as you can imagine, not only the clinicians but the families want to know what's going to happen to my child. This is a very dramatic illness. So 8 out of their 12 children completed the full study procedures. 2 out of those 8, so 25%, had a full recovery, but unfortunately 6 out of 8 had persistent motor deficits at a year. And this is a photo on the right showing some of these things that are seen, so significant atrophy, as you see in panel A there, and also in panel B, back and front. Minimal to no improvement in the children once they reach their plateau. 2 out of 8 actually had significant pain, and 3 out of 8 had depressive symptoms, reactive depression. Interestingly, all of them had improvement in those distal muscle groups. So even at the onset, we appreciated that it's more proximal, and interestingly, in the children that do improve, it happens in the distal muscle groups. And then in addition to the 8 that completed the study, there were 4 who did not enroll, and half of them actually had full recovery. So if you put that together, there's actually 4 out of the 12 that had complete recovery. So that's somewhat reassuring, but unfortunately the majority did not. Next slide. So this gets to my last couple of slides is, what is the relationship between viral infection and AFM? And is it causative? Is it associative? Is it unrelated? And this is a nice study that the Colorado group also did and published in Lancet, where they essentially took that graph that I showed you on the other slide where we're showing these peaks in 2014 and 2016 and overlaid that with their surveillance data for enterovirus D68. So we don't all across the country surveil for D68, but in Colorado they did an intensified surveillance specifically for D68. And in the shaded pink, you can see that's the times that D68 was circulating heavily, and they completely overlap with these spikes where the AFM cases occurred. So this is one of many reasons that we don't have time to go over in this lecture of why we think it probably is related, at least as a trigger for AFM. But on the next slide, we'll talk about why we're not sure it's the cause. So the CDC in that same report reported on the first 80 from this year, and when we send in our specimens, we send in CSF blood, respiratory specimens, and stool, and these are looked at very intensively for enterovirus with targeted testing, and then also undergo whole genome sequencing to look for other pathogens. And so this is the data for the enterovirus and rhinovirus testing. So there were 125 specimens from 71 patients that had confirmed disease. If we take overall the specimens, 53% of them did have a positive enterovirus, but the reason we can't say it's causative is that really only 2 of those came from CSF. And, you know, ideally you'd want a spinal cord biopsy, but we can't do that. So CSF is our next best marker of proving causation. Unfortunately, when we look at respiratory and stool, you know, it's 38 and 53% positive, but that we know that there's lots of enterovirus circulating in the fall, and that doesn't prove that it's causative for the neurologic disease. But of those that have been recovered, in the respiratory specimen, we've had D68, enterovirus 71, and some other enteroviruses. And in the stool, we have those, and as well as Coxsackie viruses, Parechovirus, and other non-typed enteroviruses. So we really can't prove causation at this point. Next slide. So now we're going to go back to our case and talk about the clinical course. And after that, Beth is going to come in and tell you a little bit more about treatment. Next slide.
So in many ways, this case is typical for what you just heard. So this child was admitted with a presumed diagnosis of AFM and ultimately was confirmed when the MRI showed the increased T2 signal in the gray matter of the spinal cord. He received a single dose of methylprednisone followed by IVIG given over 2 days. He was intubated, as I said, for the MRI and remained intubated for an additional day, was ultimately extubated to BiPAP, which he required for several days in the ICU. He received supportive care and ultimately on hospital day 27 was transferred to an inpatient rehabilitation center. At 4 months, he was still admitted at the NRH Rehabilitation Center and did not require any respiratory support, but did have had improvement of his right upper extremity weakness, but persistence of his head control problems. And in fact, this is his primary reason for being still admitted at the rehabilitation hospital today. Next slide. So just for reference of what his workup was, he had CSF studies. We used the BioFire panel, which revealed negative viral studies as well as some of the bacteria that are mentioned there. He had an extensive workup looking at serum infectious studies in the serum looking for infectious studies. He had arbovirus titers that were negative, EBV virus titers were negative, as well as CMV and EBV PCRs were negative. We looked extensively for enterovirus, looking at his respiratory viral PCR, as well as a rectal swab, studies in the serum and CSF specifically, all of which were negative. Next slide. Whenever a child presents with spinal cord changes, we do have a differential, and one of the things that we like to do is send inflammatory studies as well. So this child had an extensive workup for inflammatory markers. He had a mildly positive ANA as well as an anti-SSA. Other studies were abnormal, but probably not causative, included a low C4. He had a significantly elevated neopterin and a mildly elevated lactate pyruvate, which probably had to do with his respiratory status. Ultimately, those abnormalities were not felt to be the cause of his presenting symptoms. I'm going to now pass it over to Beth Wells.
Yep. Next slide, please. So I'm going to talk about the differential diagnosis when a patient is presenting to you not moving a limb. So there are a number of things that we think about, and of course this is after you've thought about something like trauma and pain. And on the differential for acute flaccid weakness, that includes transverse myelitis, Guillain-Barré, acute inflammatory demyelinating polyneuropathy, or the chronic version of Guillain-Barré, stroke of either the brain or the spinal cord, cerebral sinus venous thrombosis, encephalitis, which could be either infectious or parainfectious or autoimmune, demyelinating disorders, so this includes ADEM, multiple sclerosis, neuromyelitis optica, and neoplasms of the brain or spine. When trying to narrow your differential diagnosis, we want to look at a number of distinguishing features, including the history. So was there presence or absence of fever, like Roberta mentioned? Is there abrupt onset or more of a subacute onset, and over what time frame? Was there preceding weakness? Is there pain associated? And what are the risk factors? The examination, during our neurologic examination, we try to localize into the central or peripheral nervous system or muscles, et cetera. Is there encephalopathy or cranial nerve dysfunction? And then our diagnostic studies. And the core studies here include the MRI of the brain and spine, lumbar puncture, and the EMG nerve conduction study. Next slide, please. Thank you. So just to lay out the disease comparison for the most similar diseases on our differential, here we're looking at acute flaccid myelitis, transverse myelitis, Guillain-Barré, and stroke. And symptom onset is particularly important for AFM, where the onset is often occurring over hours to days, but acute, but not quite as abrupt as, for instance, stroke, which occurs over minutes. Guillain-Barré also is over more like days. We do see some progressive symptoms and some stuttering of symptoms. So where they may present with one flaccid limb, it may then progress to involve other limbs. But that's the time course that we're really looking at. Then when we talk about the weakness, we focus in on the distribution of the weakness. And for AFM, it's usually one limb. As was mentioned, it's often the upper more than the lower to start, and then it can progress to multiple. Transverse myelitis typically includes multiple limbs. Guillain-Barré, remember, is your distal symmetric polyneuropathy, usually starting in the legs and progressing up to the arms, and then progressing from distal to proximal. And then stroke is more often lateralized, especially if in the brain, and sometimes it's in the spinal cord. For reflexes, I put a comparison here, but you'll see there are kind of a number of caveats. So where we say that they're flaccid and ultimately they often have diminished or absent reflexes, they may actually be present early. So the presence of reflexes does not rule out actually any of these diagnoses, but including AFM. Transverse myelitis, more commonly we see diminished or absent reflexes acutely. Guillain-Barré, similar story, and as well as with stroke in the hyperacute phase, they can be absent and then proceed to hyperreflexic. The CSF is important diagnostically. With AFM, we often see a pleocytosis. We see that also with transverse myelitis. With Guillain-Barré, you're looking for that cytoalbuminologic dissociation, which means that the protein is high, but there's not a very high pleocytosis. And then with stroke, it's usually normal, although if it's caused by an infection, it may be elevated, the white blood cell count. And then the MRI findings are probably the most important diagnostic feature. For AFM, it's gray matter predominant, and we'll explain that further with some pictures. Transverse myelitis includes more of the white matter as well as the gray. And then Guillain-Barré, often the spinal cord imaging is normal, although we'll also see nerve root enhancement depending on the stage of the illness. And then with stroke, we're usually looking at more anterior abnormalities and specifically diffusion restriction. Next slide, please. So just a reminder of our anatomy. The spinal cord, of course, is part of the central nervous system, so there's gray matter and white matter. And I want you to look at, in particular, this central area kind of looks like an H. And so that, although it's appearing white in the pictures, is actually the area of the gray matter. And you'll see as you compare from the kind of the drawings up top down to the MRI below, this is a axial cross-section of the spinal cord. You can see, and then the area that's kind of blown up, that really symmetric, bright, hyper-intense area is where we're seeing the abnormalities of the gray matter of the spinal cord. So that's what we're looking for. Next slide, please. And so I'm going to go over some of the big picture components of management. So, and this is not, it may occur in the emergency department or during an admission, but I tried to break it down a bit by location. So in the emergency department, we're especially focused on the general evaluation of the patient, the neurologic examination. We're doing imaging urgently. We're obtaining our infectious studies, like we talked about, through various specimens, including the lumbar puncture. Because of the concern for meningoencephalitis with the presentation, very frequently we're starting empiric treatment for the infectious agents that could be treatable. So that would include acyclovir pending your HSV workup and often ceftriaxone pending Lyme. Then during, at least at Children's and at many other major centers, patients who have suspected or presumed AFM are admitted to the ICU because of the concern for respiratory decompensation. And so at that point, we're focusing on our monitoring, our supportive care, and that's where our treatments occur. These are anti-inflammatory treatments and immunotherapy, although as Dr. DiBiase is going to explain more, there's currently not enough evidence to recommend for or against it from a research-driven standpoint, but this is really what has been used and what we're doing. So, and I'll get into treatment a little bit more, but it can include the IV immunoglobulin, the high-dose methylprednisolone. Plasmapheresis is not routinely recommended, but has been done. Same with interferon. And then we consider early physical therapy, early occupational therapy to be critical for anyone with injury to the central nervous system, and it seems particularly these patients. And so I actually put that under ICU because we really want that to start as early as possible. Additionally, then we talk about long-term rehabilitation, the role of experimental therapies that have been tried or are potentially coming, and then some discussion of nerve transfer, which has been done in some cases. Next slide. So again, just to go through the treatment in a little bit more focused, when they're in the ICU for supportive care and monitoring, they're getting their empiric IV and infectious treatments. And then the strategy is really individualized, so taking into account what is going on with the individual patient, risk versus benefit, how sure we are of the diagnosis or alternatives, and the IV immunoglobulin has been, a core feature. We use the regimen that we'll use for Guillain-Barré, which, as Dr. Carpenter said, is usually 2 grams per kilo, divided typically over 2 days, although that could be stretched out if there are adverse reactions. There's some literature that the high-dose IV methylprednisolone may have been associated with some of the worst, the worst outcomes, but that is retrospective. But generally, that might be avoided, especially when you're concerned about direct infection that may not be being addressed directly. So, but we will use it especially if there's significant cord swelling associated. Currently, there are not other antiviral agents available, but that question comes up each year. And then, as I mentioned, plasmapheresis and interferon have been used sometimes. Fluoxetine is not currently recommended. There was a study that Dr. DiBiase is going to go over. Children's National was a big part of that, and showing some evidence that it can block replication of the enterovirus D68 in vitro, but there was no clinical benefit seen. And again, physical therapy and occupational therapy should begin promptly. Next slide. Okay. So there are a number of gaps in knowledge, and just to talk about the most pressing questions that we're taking into account as we work together to try to advance our knowledge and develop better treatments. The first question, of course, is what is the true incidence? So when you look at the data from the CDC, many sites, ourselves included, will say, oh, but since that time we found more cases that were not reported during those years. And so the true incidence is really probably underappreciated. There's also a big question about the role of the virus or viruses that are involved, and is it association or is it causality? The mechanism of injury to the spinal cord gray matter is still really debated. So is it direct infection versus parainfectious? Is there direct injury, or is it more of an inflammatory response? And then what are the determinants of susceptibility? So given how common enterovirus is, why are these particular individuals developing this condition? There's also a real gap in documenting systematically and working towards improving the long-term outcomes. And so within this, we think about the long-term prognosis, long-term follow-up of patients, as well as how can we better optimize treatment. Next slide. I think Dr. DiBiase is going to take it from here.
Yeah, so I think we've covered really all the key features that are important clinically and what the gaps are. And so we've been working together really hard to try to address some of these gaps, the we being not only our center, but a multi-center approach to this, because as we said, even though it's very shocking to see 1 or 2 children, it's really only a small number of kids at each center. So it really needs to be a multidisciplinary approach to get answers to some of these questions. So I'm just going to go through some of those gaps that Beth just brought up and talk about what's been going on in the 4 years since this emerged. So for instance, there was a 10-year retrospective MRI review that's ongoing at 7 major centers. I think that data may be soon completed. And the idea there was, let's go back and look at MRIs on any patient that was seen with possible spinal cord injury and see if retrospectively, oh wow, it really does fit this AFM definition, to get a better idea of what the true incidence is. There's also been a lot of effort to educate not only clinicians but also families into recognizing those symptoms. So just like that infographic that I showed at the beginning, getting people really aware and proactive on their own side when they go into an emergency room to bring it up. And then the CDC just announced with the big press release, there's a formulation of an AFM task force, which has brought together some of the key researchers and opinion leaders in this area to meet and come up with more of a structured research platform. So that's going to, the first public report from that task force is going to come out just next week at the beginning of December. The role of viruses. So there has been a lot of work at the CDC, as I mentioned, on specimens that are submitted, but on top of that, places like Colorado and other existing sentinel viral surveillance networks have really stepped up their surveillance specifically for enterovirus D68 and some of the other enteroviruses. And the idea there is if you could continue to show that there really is this absolute one-to-one correlation between the emergence of one of these unusual enteroviruses and then cases occurring soon or coincident with that, that really builds the story that it really is related to the virus, but more importantly could also help people to be aware at a major center that, so for instance, this year, Denver they actually told me we could see that it was going to be coming because they picked up that they were getting D68 and 71 circulating, and sure enough, 3 weeks after that is when they started seeing the cases. So that just helps people be more aware and not miss cases and get on top of the kids sooner. And then there have been studies at private institutions doing whole genome sequencing. So this is work done at UCSF where they basically have taken multiple specimens and then just done sequencing to look for any pathogen whatsoever. And from there, there have not been alternative pathogens isolated from spinal fluid, for instance. So even though we haven't been successful at getting enterovirus out directly, we haven't found an alternative pathogen. So that's also important information. Now, as far as the mechanism of injury, there's a very good mouse model where they took D68 enterovirus specimens from actual patients from 2014 and put them into this mouse model, and it could actually recapitulate the human disease. So it caused a flaccid myelitis in the mouse, which on sectioning the spinal cord involved the areas that are in the case definition. So this is probably going to be a useful model, but it is a mouse, it's not a human. But for instance, this was used to look at how does steroid work, and steroid actually was not good in the mouse, it actually was deleterious. It was used to look at IVIG, which it actually did not cause a lot of help, but it wasn't detrimental. And it was also used to screen fluoxetine, which is just Prozac, but was found to have in vitro activity, and that could be put into the mouse model to see if it had effect. And it looked like it might, but it did not work on the human side on a retrospective study. And then this multi-center sharing of patient data is also really important to look at mechanism, because the more you can collaborate amongst multiple institutions and collect the data all the same way, the easier it is to see that there is a direct effect of virus or not. Next slide. And then as far as determinants of susceptibilities, there are several studies ongoing to look at the potential genetic predisposition to AFM. There are case control studies ongoing at CDC where you take, match children with the same virus from their surveillance who did not get AFM compared to those who did, and try to isolate what are these determinants or biomarkers that predict that that child is going to be the one in a million affected child. And then biobanking of patient specimens for future studies and biomarkers is really important. We have here at Children's that Beth leads a biobank of neuroinflammatory disorder patients, which we hope we'll be adding to that biobank with these AFM patients. Sorry?
We've already started.
Yeah, great. And then finally, for improving outcomes, there is a multidisciplinary, multi-center AFM working group separate from that CDC task force. And we're very happy to be part of this. This is involving all the major children's centers across the U.S. and several in Canada. And we meet weekly, really over the last 3 months, or actually 2 months, and are trying to put together our heads together and also all of our resources together to come up with standardized case identification and data collection, and coming up with the questions that we think are important at the front line of taking care of these kids. So that group is going to have some reports coming out in the next couple of weeks, and that we hope that those reports will actually influence and guide the CDC task force. Next slide. So this is just a little model of the AFM multi-center working group, and it just shows you all the different subcommittees. So everyone is really invited, and all the different expertise is really appreciated. So there's a group that's really dealing with clinical assessment and management, a group that's dealing with lab methods and diagnosis, a group that's identifying research opportunities, not only just ideas for research, but ongoing projects that are going on for other diseases that could then be applied to AFM. There's a whole rehab group that's looking specifically at how to best and optimize the rehabilitation of these children. There's a neurophysiology group that looks at the role of EMG and how that can help us predict perhaps outcomes. And then there's an ICU management group, and Beth, Jessica, and I are engaged in these subcommittees. Next slide. So I think this is one of our last slides. We also have our own internal children's AFM task force, and we really formed this back in 2014, and like all emerging infectious disease task groups, it becomes very active when there's an outbreak, and then it's not that we go to sleep, but we're not seeing each other as frequently when it's an off year, but we're back together again this year. And we've really been really active trying to play an advocacy role, not just in the clinical care. So we just released an opinion editorial in an online Boston Globe platform that really talks about trying to make the public not only aware of the disease, but aware of all the work that's being done, because a lot of the news, I'm sure you've appreciated, has been sort of, it's a mystery and no one knows what's going on, and it really has scared families. So we wanted to get the word out that there is a lot going on and there has been progress made. I also was really happy that we were invited to go down the street and do a C-SPAN interview that allowed people all across the country to do Q&A with us, and I think that really helps to dispel some of the myths about the disease. And then our PR group here has really gotten us engaged with major journals, Atlantic, LA Times, and others, to get out the word that there's a lot being done. As I've already mentioned, we're still participating in this work group, and we hope to see more good things come from that. I've already talked about our multi-center participation with the Prozac study, and then I've talked about Beth's neuroinflammatory disorders program and biobank. So we're really very active and hope that the next time this happens, we'll be even closer to more answers. Next slide. These are just some references. I think Danita will share the slides later, so if you want to later look at these. But the most important at the top are the CDC links, and anyone can go to CDC link anytime. Just put in AFM, and there's all sorts of really easy to access data and information for the clinicians, and also infographics if you want to hang them up in your office for families. Next. Oh, that's it. So, and we purposely left about 15 minutes if there are questions. I did leave up some phone numbers for you all that are out on the front line in your clinics to make sure you're aware of the Children's Lifeline, which takes you directly to the ED and transport group, and essentially you say, look, I need this kid, you need to take care of this child, and they'll do the rest. So it's a very easy number to remember. I can remember it in the middle of the night when I'm typing a slide, It's 202-476-LIFE. And then if you ever want to talk to any of us, either specific about AFM or other issues, this is our numbers for the ID division and the neurology divisions. So we'll be here and are happy to take questions. And I think, Danita, will we see these, or will you let us know, or how does that work?
We can try opening the phone line. Sometimes the background noise is manageable, and sometimes it's so chaotic that we have to shift back to chatting. But I don't know if I've seen any other questions chatted.
I don't know if I have a question, actually. Is the Stafford group on the line? Because they actually had mentioned they wanted, they had a case and they specifically had asked for some CME. So that's sort of what spearheaded all this. But I'm curious to hear their experience.
Should I unmute everyone?
Hey, let's try it and see what happens. The pilot.
They're fine. She might be a little sleepy, might be a little irritated, that might get a little slight fever. But anything unusual, please call. Or if she's not eating at all, please start vomiting.
There's our challenge.
Yeah.
Okay. Actually, Danita, let's try muting, and we'll switch to chatting for a second.
Right. Any questions before I see her? No.
Actually, one of the are there adult cases?
Adults, and the oldest patient so far in the 4 years was 32 years of age.
And outside of North America, is there similar, epidemiology going on out there, or?
Yeah, there is surveillance going on for both the disease and the enteroviruses in Europe, and they are also seeing cases. And I think it hasn't been as appreciated there, and I'm not as up on the literature there, but I know that there has been spikes in Europe this year. So I haven't heard more of the detailed data yet, but it's definitely not just the U.S.
And has some smart person figured out why the virus is every other year?
Well, we've known really enteroviruses tend to do that, but I don't know why. I don't think anyone knows why exactly enteroviruses do that. It probably has something to do with when you are exposed, you have some sort of immune response that probably wanes over a 2-year period, and then there's just more susceptible people in the population, so that these things can reemerge again. But
Dr. DiBiase?
Yes.
There are several people from MWH in Stafford, and they had 2 cases that originally presented.
Yes.
And then Melissa said, why are Bulbar symptoms so prominent on the CDC flyer when the recent case review shows UELE? Should we be calling consults for asymmetric facial weakness?
Oh, well, I think so that's a great question. We certainly don't want to alarm people that these cases are presenting looking like your typical Bell's palsy. So in the absence of weakness elsewhere, I would not recommend activating an emergent response to a Bell's palsy.
But other things.
But yes, but if it seems like it's more, if it's atypical or you're questioning that there's something else going on, we're always happy to discuss or evaluate the patient. And also, just as you always would if you see other cranial nerve deficits, that would be of greater concern. Knowing the association with Lyme disease and Bell's palsy, we do evaluate children in the emergency room, but it wouldn't be with the same sense of urgency that you have with regards to, getting someone in as quickly as possible for an acute weak limb.
Yeah, and I think the case that I presented in some ways highlights, I think, what we're used to looking for. So the case that I presented was presented as right upper extremity weakness, but on reflection, really his most prominent symptom was his inability to hold up his head. So we've done a good job in some ways of training people what to look for. So I think we've underappreciated how many kids do have bulbar symptoms, but I think I would agree that you want to see that in association with something else. So just a facial palsy, I think, was probably pretty low yield, whereas a child with weakness in the arm with a facial weakness would be pretty high yield. So we're pretty commonly seeing bulbar symptoms, but not commonly in isolation.
Allison says she had a question about reporting the cases, as they've received several notices to make sure they were reporting any suspected cases to the Virginia DOH. She noticed on the reporting map during your talk that there was only 1 in Virginia and 0 in D.C. There were 2 cases that originated at MWH reported. Should they be following any reporting or suspected cases after the diagnosis is made, or is that done through Children's?
If they come to Children's, we report each and every case, and they get reported to the resident state of the patient. So even though I told you we had 12 patients, actually none of ours have been D.C. residents, so that's why the number is 0 in D.C. But so, for instance, the ones that have been transferred to us have been Virginia and Maryland residents. But we do report once they come here. However, if you have a case, you can still call your health department and give them a heads up, and that's what they do. They follow up and make sure that, the ball's not dropped, and they would follow up with us and get all the additional data that's needed. So you can't over-report, but we will definitely report each and every case that comes to Children's.
Dr. Gupta says, has this been reported in countries where polio has not been eradicated?
That's a great question. There's 4 countries that are still, kind of rampant. And unfortunately, they're war-torn and very politically unstable areas. So I don't think there's been or health department presence at those places to really know what the incidence is there. So I don't think we know, but that's a great question.
That's it.
Is there any way to just unmute the Stafford folks? Because I would love, since we have a couple minutes, just to hear a little bit about their 2 cases, if they're willing.
So I have Allison.
And not in great detail, but just, how old were they and, how did they present? Were they upper extremity or lower? How did they come into their facility?
What was their experience?
Yeah, what was their experience with getting them to us? Hopefully you're going to say it was easy, but I don't know.
Let me see. Allison is no longer on the phone.
Okay. Well, it is getting late in the hour, so I'm sure people have to get back to patient care.
Yeah, and the other Stafford person has dropped off as well.
Okay. All right. Well, if there's no other questions, thank you so much for letting us share what we've experienced so far, and please don't hesitate to call us if you have questions or, any suspicion that you have a case. Don't hesitate to call us.
I want to thank Drs. DiBiase, Carpenter, and Wells. Thanks, team, for really sharing your expertise and providing the perspective to our community practitioners, both those in primary care and in other community hospital settings, and for sharing the work that you are doing with other children's hospitals around the country. So thanks so much. We will try to make copies of the slides available, and we're having to do CME credit manually, so you saw the slide about pushing that information to Danita, and once the recording is made available, we will see a way to get that posted as well on our website. So thanks, everybody, and we look forward to gathering again. Thanks.